And thank you, Dr. Chitra, for giving me this opportunity today. So what I'm talking about is a little more advanced steps in the management of a posterior capsular rent. So here you see a posterior capsular rent with a lot of cortical matter still inside, and this is a typical puncture of the posterior capsule when the phaco tip hits the posterior capsule. Now the question was, how do I prevent this rent from moving towards the periphery, and how do I do the minimum of manipulation to get a good acceptable outcome? So the first step that you see, which we do in any posterior capsular rent, is to stabilize the chamber with an anterior chamber maintainer. So what you are seeing here is an anterior chamber maintainer, which is attached to a bottle height of 30 centimeters, which gives you an IOP of about 24 millimeters of mercury. So at 24, your chamber is stable at all times and you can do all the maneuvers that you want. So now I'm going to show you the anterior chamber. ACM is in place. The chamber is stable. I think the vitreous is disturbed. It should be disturbed. So my first step would be to stain the vitreous with triamcinolone and do a vitrectomy. Now I'm doing an anterior vitrectomy, but ideally is to go through the pars plana route these days and do a vitrectomy from behind and pull the vitreous behind. That gives you more chances that this rent will not extend to the periphery. However, here also I was lucky that I could contain the rent, but let's see how I managed it. So a little vitrectomy behind the plane of the posterior capsule rent. I bring the instruments out, and you see the chamber is so stable that I don't have to push in viscoelastic from the other port before I bring my instruments out. Now another trick, I'm using a vitrector in the IA cut mode, a 23 gauge vitrector, and in the IA mode it works like a bimanual irrigation aspiration system, and in foot pedal 3 in the cut mode it works like a cutter. It cuts the cortical matter along with any attached vitreous strands so that there is no tug on the vitreous and the retina. So chances of CME or retina problems are minimized. Now, once this cortex cleanup is clear, and if you, as you see, my next target is, can I do a posterior CCC and round off the edges so that this rent does not run out? So I have one, again, I'm not doing this under a viscoelastic. I'm just doing it under the anterior chamber maintainer, and hold this anterior capsule from the tip and pull it in to round off one edge. This second edge also needs a little rounding here. So I'm rounding off this second edge. And I think I have a fairly controlled posterior capsule to put in an implant. Now the next question is, what implant? Do I put an implant in the bag or do I put an implant in the sulcus? In this situation, I could have done both because I had controlled the posterior capsular rent, but I decided in favor of a 3-piece IOL in the sulcus. And notice this 3-piece IOL is also being injected under cover of anterior chamber maintainer. And if you notice, when I'm putting this implant in the eye, I want the chamber to be a little harder because just 24 millimeters of mercury chamber is not a hard enough eye for my maneuverability within the eye. So I raise the bottle height from 30 to 40 by 10 centimeters. The eye becomes a little more firmer and I can put the IOL in the eye. That is one. Number two, this IOL should open in front of the iris. Because if you try to directly put it into the sulcus, the chances is that sometimes it could dip and go back into the vitreous and disturb the vitreous. or it could fall back into the vitreous. Once opened in the sulcus, you can easily dial it into position. And once you have dialed it into position, you can do a comfortable posterior capsule. So you fixed it to the posterior to the anterior capsule, and the lens is central. It is in position. There was no risk of the vitreous falling into the vitreous cavity because you're not used. Visco falling into the vitreous cavity because you're not used the visco at all. So the risk of a secondary glaucoma or inflammation in the vitreous cavity because of the visco falling in the vitreous is negated. So it works out well, and the technique doesn't seem to be too complicated. It can be easily done by everybody.